So we'll go on to the next topic, which is Pediatric Respiratory ECMO. This again will be a pre-recorded session presented by Dr. Lakshmi Raman. She is Medical Director for ECMO Program and Associate Professor at the UT Southwestern Medical Center. And she is an active member of ELSO and interested in brain injury and care of ECMO patients. So we'll go to the top.
I thank the organizers for inviting me to this talk in this conference. It's too bad that I can't be in person, being in my hometown of Chennai. But I will think that I'm in Chennai and give this talk. So in the next 10-15 minutes, I'm just going to overview pediatric respiratory ECMO, the common indications, and some of the challenges. So this is from the international registry. As you can see that you have neonatal, pediatric, and adult ECMO. And our focus is going to be in this section of the pediatric pulmonary ECMO. And you can see so far there have been more than 11,000 patients supported as of 2021. This is graph of showing the annual respiratory runs. And as you can see, since the ELSO registry data was started entering in 1990, you can see that pediatric respiratory ECMO is a growing field. And you can see more and more patients are being supported for these indications. This is from the SWAC ELSO region, and you can see again the number of patients that are being supported for pediatric respiratory reasons. So what are the common indications for which they are placed? As you can see, these are some of the disease categories that are entered in the ELSO registry. And there is this big bucket.
Sorry to interrupt, man. This thing is not in slideshow. Can you?
It's not in slideshow. Yes. There we go. Can you see this?
Yeah.
Are you seeing the presenter view, or are you seeing the other view?
It's not in presenter view.
It's not in presenter view. One second. I'm going to leave and share again. Give me 1 second. Is that better?
Yeah.
Okay, good. So these are the diagnoses, and as I said, you can see there's a big bucket which says other, and this is I think ELSO registry is trying to improve the way we enter diagnosis, and in this other, actually there is a big bucket of septic shock patients and other diagnoses that are not commonly we see. This is for the SWAC ELSO region. You can see that these are some of the diagnoses that have been entered in the SWAC ELSO region for pediatric respiratory support. So what is the mode when we talk about pediatric respiratory support? Because you do have to remember that these are smaller children, but you can see predominantly it is VV ECMO. These are the total runs, and this is from 2016 to 2020. You can see this is the VV runs, and we have some challenges with cannulas, and so you see there is a big portion of BA runs as well, and then there is some conversion from VV to BA. These are the conversions, and then there are these other categories. And this bottom graph is for the SWAC ELSO region. Again, you can see that there is VV, mostly predominantly VV, but there is some VA support as well. So what are the advantages of doing VV support? I think we all know that the circulation of well-oxygenated blood through pulmonary and coronary beds. The big advantage is you preserve cannulating the carotid arteries, especially in infants and smaller children. And then you still maintain pulsatile systemic flow, which is very important, particularly for the brain. And then you save your systemic circulation from thromboemboli. And then the cerebral blood flow is not highly oxygenated or pressurized. And so there is certainly a decreased risk for neurological injury when you are on VV ECMO. And then you also avoid LV afterload and RV afterload. But what are some of the disadvantages, particularly in younger children? There is no capability, as we all know, for circulatory support. Recirculation is a big issue. And then many times in VV, we find that these patients have renal insufficiency. And this is well documented in the also registry that VV patients have more renal insufficiency. And then again, oxygenation is limited by the amount of support that you can give. And particularly, this is challenging in younger infants. So how do we know that the patient has adequate support? They have to be able to maintain a normal pH and PCO2. The PaO2 is anywhere between 45 and 80. You maintain saturation anywhere between 70 and 85, depending upon the support and the activity and the consumption that the patient has. I think that keeping the hemoglobin higher is a little bit of an older concept, though we do try to keep the hemoglobin lower to reduce the viscosity and avoid more hemolysis. And certainly the patients have to be able to maintain adequate perfusion, otherwise you are going to be in trouble. And then we monitor cerebral venous saturation as NAIRS monitoring, and we make sure that they have adequate end organ perfusion by cerebral venous monitoring, SVO2, urine output, and other things. So what are the types of BV cannula? Unfortunately, in younger infants and small children, it is often very challenging to do two-site BV. But luckily for us in the Western world, we have a lot of double lumen cannulas, though this has been a challenge in the last 2 years because previously Origin was producing double lumen cannulas and then they stopped production, and now we have the newer Crescent cannulas, and I'll talk about it a little bit. And then you have the Avalon and the Crescent cannulas. So the Avalon cannula, what is the experience? And I know Dr. Raghavendra in his previous talk mentioned about the Avalon cannula. Some of the challenges is, the Avalon cannula, the tip sits in the IVC, and this requires placement under fluoroscopy. And so that can be a challenge, though in our ICU, we do insert these cannulas in the ICU itself, and we do not do it in the OR suite, but we have to bring the C-arm, and the patient has to be on a fluoroscopy compatible bed. And then any movement of the cannula that happens has to be done under fluoroscopy guidance. And then some of the challenges with the smaller cannula, this was an early experience that was published with the Avalon 13 French cannula used for neonatal respiratory support. And they reported a lot of complication, and particularly the scary complication was perforation of the right atrium requiring sternotomy. And that's a big risk. And personally, I have witnessed a loss of a patient by this perforation. And so this is a big challenge. And that is why the Avalon smaller sizes did lose being favorable, and we went on to the Origin cannulas. And then the Origin was stopped producing more than a year and a half ago. And then many neonates and younger infants, we had to resort to VA cannula. But then in the last few months, we have been lucky and we have had the Crescent cannula that's produced by Medtronic. And the smaller sizes, they do have both similar to the Avalon, and they have better flow characteristics. And the smaller sizes, the 13 French, 15 French, and 19 French, are like the Origin where the tip ends in the right atrium. So you don't need a fluoroscopy, and it can be just done with echo guidance. And the bigger sizes like the Avalons end in the IVC, and they do need fluoroscopy guidance. Again, what are the challenges with BV cannula? Again, we know that recirculation is certainly an important this one. And for us in pediatrics, it's even a bigger issue because often when we even take a chest x-ray and put a plate under the patient, you can cause some movement of the cannula and you can start having recirculation. And sometimes you have not enough support and you may have to think about adding additional drainage cannula. And in pediatrics, because their RA is pretty small, even if you give them a big dose of diuretics and they have urine output and their intravascular volume is reduced, then you find that they have more recirculation. So that can be a challenge. And then often our immediate instinct is to increase the flow, and we all know that increases the recirculation. And again, in pediatrics, it's hard to sedate patients. And so if they have increased cardiac output by tachycardia and other things, then you have and increased cardiac output with the rapid transit, and which can then cause more recirculation as well. And then I know Dr. Aravinda spent some time talking about ventilator management, and it's very similar in pediatrics. The goal is to allow lung rest when the patient goes on ECMO. And often the common mistake that people do is to try and recruit the lung in the early stages when it's in the inflammatory phase. And so that is something that you want to avoid. So what does the ELSO guideline say? And this is a recent respiratory guideline that we published in ELSO that came out last year. And what is the recommendation? We want to keep the oxygen definitely below 50%, ideally below even 40, 30%. Limit the inspiratory pressure under 25. The PEEP, certainly in pediatrics, we try to keep it around 10 or 12, and then give them a rest rate usually around 10. And so that is certainly important. This was a study that one of my fellows did, where we looked at an international survey on the ventilation practices across the globe. And we looked at what are the top 5 rest modes that people use for ECMO patients. And this is pediatrics, mixed patients, and adult respiratory patients. And as you can see, pressure control was the most used in terms of rest mode of ventilation. But when it came to recruitment mode, certainly in pediatrics, still pressure control was the most favored mode, though you did have some centers which used the bilevel or the APRV, and then high frequency is certainly something else that we use in pediatrics. And PRVC was not a very favored mode. It was much lower in the list of things. So pressure control by far was the most favored mode, both for rest and for recruitment in pediatrics. And then the next other favorite thing that people talk about is extubation on ECMO. So what are the potential benefits for extubating patients on ECMO? Certainly, there is decreased risk of ventilator-associated events. There is decreased occurrence of unplanned extubation, and a big decrease in the need for sedation and increased comfort. Patients can participate in physiotherapy. We can let them have PO. These are all some advantages. But what are the potential risks? There is insufficient gas exchange. The first and foremost, before you decide to extubate the patient, you do want to make sure that you have adequate support from your ECMO. Otherwise, it's going to be a big challenge. And I will tell you, having extubated patients on ECMO at the bedside, it is certainly a culture that people have to get used to, both nursing and respiratory therapists, parents, everybody at the bedside. They do have to get used to the fact that these are patients who are going to be in distress, and that they will have some desaturations, and not having a ventilator at the bedside can sometimes be discomforting to the intensivists who are at the bedside. And if your patient is in respiratory failure, please, significant respiratory failure, and you are not able to support them adequately by ECMO, not a good idea to do it. And if your patient needs respiratory clearance and airway clearance, then certainly extubation is not the way to go. So this, again, in our international survey, we asked people if they will extubate and what was this one. And this was very different from the previously published survey just 2 years ago, where only 1% of the practitioners were extubating their patients. But by the time we published this data and we had this data, you can see that a fair number of them were extubating their patients. You can see in less than a week, there were 14.5% in pediatrics, and certainly much more in adults. They were extubating the patients who were on ECMO. So that does seem like it has been something that people are resorting to these days. So as I said, what are the things that you want to look for when you're thinking about extubating patients? Patient's clinical condition needs to be stable, awake and cooperating enough without risks. Secretions need to be manageable. You should not have any further need for interventions like bronchoscopies, and they need to be able to meet the gas exchange criteria. And this is from the ELSO guidelines that published on extubation from 2015. So what are the other interventions when you have a patient with respiratory support that you are on ECMO that you need to think about when, for instance, if your lungs are not opening up at the time you think that they should be opening up? Certainly something that we tend to do is we do bronchoscopies to make sure that their airways are not completely plugged with thick secretions and they are full of gas. So that's something that we do. And after we have gone through that and if we are still having trouble, then we certainly hide them down for chest CT to see what is the degree of bronchiectasis or fibrosis that they have. And then, of course, before you think about whether this is going to be a bridge to transplant or you're going to withdraw support, then it is important that you get a lung biopsy to know what their diagnosis is. And other interventions that you can certainly do when you have your patients on respiratory ECMO is prone positioning, though it can be pretty challenging unless your patient is completely sedated and paralyzed to do that on ECMO. And this is, I actually took this from the adult respiratory guideline that Joe Tona published just recently in 2021, where weaning ventilator, what are the things that we want to look at? Certainly you want to be making sure that your patient's compliance is better and they are having enough tidal volumes and this one. And these are the stepwise things that we do. We gradually reduce the FiO2 on the circuit, and we want to make sure that the patient is not needing more than 40 or 50% oxygen. We certainly have to reduce the sweet gas. And then we do a cap-off trial. And many times we do a cap-off trial, even more than 2 to 3 hours. We keep them capped off for even almost 24 hours before we decide to decannulate the patient. In the next few slides, I'm going to talk about some other considerations for pediatric respiratory. This one. So when would we in pediatrics consider veno-arterial support? Certainly, if you have small infants and placing these small cannulas is a challenge and their veins are not big enough, then we do resort to VA ECMO. There is certainly a need for, if there is a need for hemodynamic support, then consideration of VA ECMO support is important. And then sepsis is another big bucket for us. And then if you do develop RV dysfunction when you are on VV, then conversion to VA is something that we think about. So what are the VA cannulation strategies? In infants and young children, certainly who are less than 30 kilos, carotid artery is the way to go. In older children, greater than 30 kilos, if their femoral artery is big enough, then we try to do femoral cannulation. And if they have vasodilatory septic shock needing higher flows, then consideration of central cannulation is certainly something that we resort to. In the next few slides, I'm going to talk about the two populations, mainly sepsis, septic shock, and then an immunocompromised patients that form a big bucket for us, particularly here in the Western world. So this was a recent study by Ram Ramanathan and Graham McLaren, on, which was a systematic review and meta-analysis on the role of extracorporeal membrane oxygenation in children with sepsis. And they, at the end of the study, they found about 23 papers, and they found that the overall survival was about 50%, very close to what we find in the ELSO registry. And this was a pediatric patients. The neonatal group, some had a higher survival, close to 73%. And the pediatric patients had something less than, slightly less than 50% in this meta-analysis. And when they looked at the meta-regression for various other factors, there was nothing else that was significant in terms of hospital length of stay, ICU length of stay, the need for renal replacement therapy, or other ECMO factors. So in conclusion, for sepsis, ECMO in sepsis is certainly feasible. We tend to do that at least about 15 to 20% of our ECMO runs in our ICU is certainly for sepsis. And higher survival we see in neonates. And then we always talk about central cannulation if we think the patient is in significant vasodilatory shock and we are not able to support them adequately by peripheral cannulation. That is a discussion we have at the bedside. ECMO in oncological disorders certainly pose, they are a special group of population and it is very challenging. If you look at the first edition of the Red Book in 1995, it said that it was an absolute contraindication. Why? Because there are concerns that they have baseline coagulopathy, they are in an immunosuppressed state, and uncertain outcome, and these are patients at big risk for fungal infection. So certainly this is a very challenging group. However, this was a study by Gao et al. Who sent a survey. This was published in the early 2000s. And he sent a survey asking if you would oncological diagnosis be an absolute contraindication. And you can see among the practitioners, about 78% of them said that they would offer ECMO. Only 5% of them said it would be an absolute contraindication, and 17% of them said that that would be a relative contraindication. And this was a study that Gao did with the ELSO registry, and this is actually unpublished data by Veronica Garcia. And you can see this is from the early cohort, and this is from the later cohort. And you can see these were patients supported for oncology, and this was for stem cells transplant. And you can see this is the percentage of respiratory support. This is for cardiac. And the mortality on ECMO survival, you see survival is about 45%. Survival to decannulation went up to from 42% to 55%, and survival discharge went up from the first era to from 35% to 48%. And these are some of the reasons for their mortality. And interestingly, even stem cells transplant, from Gao's experience in early on to Mateo's publication in 2014, where he looked at the ELSO registry data in this group, you can see that the survival to discharge is not 5%, it is now about 10%. So actually in our unit, what we have done is when we get patients with oncological disorders or some other malignancy, right off as soon as they get admitted to the ICU and are approached close to intubation, we have a discussion. Are they candidates for ECMO? And then we also categorize them. Yes, they can be candidates for VV ECMO, but we certainly would not be doing ECPR, or we may not even be offering VA ECMO to these patients. So I think that kind of early discussion and a multidisciplinary discussion is certainly helpful in this population. This is actually a study that we are leading with from UT Southwestern. One of our fellows is leading this study. It is the hematology and oncology pediatric patients supported on ECMO, called the HOPE study. And we now have more than 18 centers participating in this study. Here we have recruited, it is a retrospective study where we have recruited patients less than 18 years of age, and anybody who has required ECMO with these of the diagnosis. They should have either an oncological diagnosis or hemophagocytic lymphohistiocytis or HLH or stem cell transplant. So we are still in the data collection phase, and this is some preliminary data that I have. We so far have 75 patients, and as you can see, this is the mean age and male to female ratio, and this is kind of some of the division by their underlying race. And what were the overall? You can see it's not that terrible. Their overall survival is close to almost 60%. And their survival to discharge was almost 43% in overall group. And certainly the cancer group is better than the HLH group. And the stem cell group, surprisingly, we were actually surprised with the survival, but we have to go doing a deeper dive into this data to see really who are these patients, because these days we do stem cell transplant for a lot of non-oncological disorders. For instance, Wiskott-Aldrich syndrome, sickle cell. There are a lot of non-oncological reasons why patients get stem cell transplants. And maybe these are the patients who have better survival compared to somebody with incurable AML who is getting bone marrow transplant. So I think we certainly have to distinguish that group. And then when we looked at the cancer type itself, B cell ALL and T cell ALL seem to have a pretty high survival compared to just solid tumors or other hematological cancers. And then when we looked by configuration, it was no surprise that the VV patients had higher survival compared to VA patients who are probably a much sicker group. So in summary, certainly pediatric respiratory ECMO is a rapidly growing field. We are pushing the envelope each day. Newer equipment makes it easier and possibly safer. And then certainly the advent of smaller bicable cannulas have been very advantageous. However, much of this is done without evidence, and certainly we need more research to standardize therapy. And that was one of the hopes when we started doing this multi-center oncological study. It is right now a retrospective study, and I think we will have close to more than 200 patients in this database. And we are hoping to make this a prospective database where we will be collecting data even before they go on ECMO, and can we learn something from this group? I think this is the last slide that I have. And with this, if people have questions, I'm happy to answer any questions.
Good morning, ma'am. First of all, I will like to congratulate you for such a elaborative presentation on such a complicated and important topic. I have a couple of questions, but first, I would like to house to ask any question if they have.
Lakshmi, good evening. Sunil here.
Hi, Sunil.
I miss you here.
Yes, it's my hometown, man. Unfortunate that I can't be there.
I know. Lakshmi, from the SWAC numbers you have mentioned over there, there are West Asian countries and South Asian countries in that. Our numbers, especially from India, are quite low. People do ECMO, but they are not projected. The data is not entered as an ECMO ELSO center. That may be one reason the numbers are low.
Yeah, that's what my thought was as well. When I saw the numbers of 15 and 20 and all that, I thought maybe people are not entering the data into the ELSO registry. Yes.
One of the measures on ECMO is lactate as well as an indicator of tissue perfusion, especially in cases when hypoxia is a problem and people are struggling to increase hemoglobin volume and all these things. Then some knowledge about understanding the tissue perfusion, and once oxygenation is okay, hold tight and see. That should be something implemented into regular practice and knowledge as well. I think that is my opinion. Last question is about your anticoagulation practice there. Do you use heparin or direct thrombin inhibitors?
Well taken point. Yes, lactate. We every day measuring lactate as a marker of end organ perfusion is very important. I'm sorry, I forgot to mention that in the slide, and thanks for pointing that out. Yes, lactate. We look at lactate, urine output, NIRS, patient exam, of course. Are they warm, well perfused? Do they have good pulses? Those are all important indicators of end organ perfusion. As far as anticoagulation goes, we just finished our randomized study on direct thrombin inhibitors. So we do use direct thrombin inhibitors. And I think there are lots of studies that have been recently published in the last couple of years where people are moving on to direct thrombin inhibitors. And personally, I can tell you, just based on my experience, direct thrombin inhibitors are.
Chutney కావాలి దోశ పప్పా చట్నీ కావాలా చట్నీ.
So the direct thrombin inhibitors are certainly an advantage in terms of they get very stable anticoagulation, and so you spend very little time talking about anticoagulation. But you have to remember that in low flow states, because of its autoclaving and half-life, they can easily clot your connectors and things like that. So that is something to remember. And when we do use heparin, it's always a daily discussion of what are we going to follow. In neonates and younger children, it seems like PTT is the better way to go. But otherwise, we do use anti-10A and other, or We do follow tests as well as an everyday measure. I don't know if I answered that question, Sunil.
Yeah, yeah. Thanks, Lakshmi. Have a nice day.
Hi, I enjoyed your talk. During your introduction, they mentioned your interest in neurological complications of ECMO. And as we all know, they are one of the most devastating complications you can ever have, especially cerebral bleeds. Do you have any insights into how we can predict or prevent them?
So I think a very nice study published by Eddie Fan in the Blue Journal that came out from the ELSO registry that looked at rapid changes in CO2. And certainly that is something that I think we can control. And we are getting ready to publish the similar data in pediatrics and neonatal ECMO as well. That rapid changes in CO2 can put your brain at risk for neurological complication. And I think there are some studio-centered adult studies also that have shown that. So in fact, what we do in our center is
நான் கொஞ்சம் தண்ணியில் சின்ன சுடு பாப்பா
we look at the patient's CO2 and match our gas on the ECMO circuit. And we also take time to drop the CO2. For instance, if the patient's PCO2 was high from ARDS, say for 24 hours, we then take at least a good 12 hours to get their CO2s to normal. So for sure, I think that is one thing maybe if we can implement in our practice, and that is something that we can do. And then some of the things that in my own study that we have found is changes in hemodynamics can certainly affect your cerebral perfusion. And I don't think I have enough clinical equipoise to suggest any intervention right now. These are all mostly retrospective research studies that I have done, and some others there's a group in France also that has looked at change in CO2 and in the setting of hypotension versus hypertension, how they affect your cerebral autoregulation and how it can put your brain at risk for neurological injury. But that I don't think we have enough data to make any clinical recommendation. But I think we have enough data now from the ELSO registry and from both in adults and now in pediatrics, which should hopefully be soon published from our group in the next few months, that would say that rapid change in CO2 while you go on ECMO is injurious to your brain. And we all know that the oxygenators are very efficient. So we need to be very cognizant of that. And that is certainly something in our control that we can do. And then once you do identify injury, maybe some neuroprotective measures, simple things like head of the bed elevated, keep their sodiums high. And then we do a lot of neuromonitoring. We do early EEGs to look for seizures. We look for asymmetry and things like that.
Do you titrate your anticoagulation looking at both APTT and anti-factor 10A levels?
Luckily in the United States, we can get all the tests. So we get all the tests often. And then there is always the question of what are we going to follow today? And I think anti-10A, we have found that it is not very reliable in neonates. And because it is a plasma-based test and it is a chromogen assay, it's not reliable when you have hemolysis or hypertriglyceridemia or hyperbilirubinemia. So then we have to resort to PTT, and then we also look at our TEGRs, and we titrate to a goal of anywhere between 20 to 40.
Dr. Lakshmi, this is Dr. Poonam here. Excellent talk. Just wanted to ask, while on the intracranial hemorrhage thing that you mentioned, does your heparin high dose on the 5th or 7th day, does that high dose of heparin in any way lead your patients towards intracranial hemorrhage? And does your TEGR at that time, if there is a cutoff of 18 or 20, as you said, If it is less than 20, does that matter for intracranial hemorrhage? Is there any experience with that?
I often feel that anticoagulation is a stepchild that's blamed for intracranial complications. I think some single center studies, and including our own, have not pointed to that. But I also think increased anticoagulation in the setting of, say, thrombocytopenia, hypofibrinogenemia, and altered hemodynamics can put your brain at risk. But to your point, have we looked at TEGAR itself around the time of bleeding? I don't think we have. I don't think we have enough patient numbers to comment. I think the biggest experience of using TEG in the setting of intracranial bleed is from the trauma population.
Agree.
And I think they do use TEG real time to manage these patients in the trauma bay. We actually did a pilot study of TEG for our trauma patients in pediatrics, and we did not, unfortunately, find correlation of TEG abnormalities with the need for massive transfusion protocols or patients who were at risk for major bleeding. But I think there is some data in the adult world that does say that you can use TEG real time to manage that. And unfortunately, I don't think we have enough patient numbers for me to eloquently say, oh, this is what happens with the TEG during the time of bleeding, and this is what I do. But I am often worried if my patient is anticoagulated and also has thrombocytopenic, is hypofibrinogenic, and especially a neonatal brain, then I say, better not do that. In fact, we right now have a CDH who's on ECMO, and that's exactly the conversation we were having this morning. Please don't let this happen. So I don't know if I answered your question, but
Good. It does. It does. Thank you. Looking forward to seeing you.
yeah.
Madam, my question was also on anticoagulant strategies only. The first thing I would like to know the use of, you have any experience of use of bivalirudin in these patients? Because the subset of patient we manage often, although these kind of the patients was not there in your presentation or study, they are the post of ARDS after the cardiac surgeries. Most of them are infants. So I would like to comment you on the bivalirudin if you have any experience, and what will be the dose, because in most of patients what we face after some time, in few patients, not in most of, you can say, the heparin resistance is there. So what is your comment on it?
Yeah, but as I said, we have just finished our study, and we will hopefully soon be publishing the data on bivalirudin. And actually, in our cardiac ICU, they use a lot of bivalirudin, particularly in the bad patients. I don't think they have published that data, but there are enough publications now in pediatrics. There is a case series from Mayo. Then Dr. David Case has published his experience of using bivalirudin on CDH patients. But I think you have my email from the organizing committee. I'm happy to share the protocol that we use for bivalirudin and the monitoring that we aim for in terms of PTT. So we do use only PTT. Of course, we know that's kind of the thing. But unfortunately, sometimes what happens is, and with bivalirudin, you get what is called a plateau effect, where your PTT goes up and then it kind of plateaus, even with high doses of bivalirudin. So when that has happened in a couple of our patients, we have sent direct thrombin studies. And unfortunately, so far only a research study. And just now recently in our lab, we've been able to start measuring bivalirudin levels itself. But I'm happy to share the protocol if anyone has questions. I think it's a good drug. It is 20 times more expensive than heparin, for sure. And even with our pilot study of 15 patients in each arm, we found there was a reduced need for PRBC transfusions. And that is what has been previously published as well. People find that the overall cost of the therapy is lower, even though the cost of the drug itself is more expensive.
Madam, my next question is regarding the ventilation strategies also. Although it was very clear the guidelines are there, but still in FiO2, what will the upper cutoff limit of FiO2 you will allow in these patients? Because what we see in our daily practice, that the 50%, most of time now the patients are ventilated with FiO2 more than 50%. So what will be your recommendation? We all know that oxygen causes toxicity and it can cause damage to ARDS lung rather than improvement. But still we have an idea in back of our mind that it also helps in decreasing the PA pressures, and we believe that the post-cardiac surgical patients, they are already have pulmonary hypertension or they are experiencing PA crisis. So the increased FiO2 can help them. So madam, what will you comment where we should draw a line that this is the uppermost FiO2 we will allow a patient in post-operative setting on ECMO?
I think the only published evidence is from our multi-center VV study led by Matt Friedman. This was published now maybe 2-3 years ago, I want to say. And in fact, we were a big participating center in that because we have a lot of VV patients. So when they looked at all the factors, but of course, these are not post-op cardiac patients, remember, so you have to take for what it is worth. This was from a respiratory pediatric ARDS patients who were supported on VV ECMO. And they looked at various factors for mortality. Interestingly, the high ventilator oxygen was the only factor that they found was associated with mortality in this group. So I feel like I'm very a big proponent that we have to keep under 50% ideally, or if not at least under 60%, because that 60% comes from the ARDS literature, where we say more than 60% is associated with oxygen toxicity. And my point is, you're already put the patient on ECMO and subjecting to the risks of ECMO. Why now do we want to subject them to the risk of ventilator-associated problems as well? So, but of course, if your ECMO support is not great, then everybody's tendency is to turn up the vent oxygen. And that's an ongoing battle at the bedside. But from that multi-center data, the one thing that was associated with mortality was high oxygen. So if that is of any message, then I think that is important. And in cardiac patients, I mean, they are on VA ECMO. So I'm not even sure why you would need to have vent high oxygen to keep their oxygenation high. I mean, I agree that if they are having pulmonary hypertension, maybe using pulmonary vasodilators, i.e. nitric oxide or other drugs to reduce their pulmonary vascular resistance will be something that I would choose over oxygen. Did I answer the question?
Yes, ma'am. Yes, ma'am.
Okay.
It's quite important.
Okay.
So, ma'am, in interest of time, we have to take next
Yes.
speaker. Thank you, ma'am.
Yes. Thank you very much. And I'm sorry I couldn't be in Chennai.